Welcome to this PowerPoint covering the cranial dysraphisms. This slide provides an overview of the full written chapter, where an overview of each of the cranial dysraphisms is provided along with their various anatomical classifications. The embryology, genetics, and epidemiology of each are covered, along with key diagnostic and management pearls. The cranial dysraphisms can be conceptualized along a spectrum of severity, with the cranial dermal sinus tracts and cranial meningocele less severe. The prognosis for encephalocele varies considerably and is dictated by the size and contents of the encephalocele. By definition, encephaloceles require herniation of intracranial contents and are subdivided between primary and secondary encephalocele, where primary are congenital and secondary are acquired, such as after surgery or after infection, and also anatomically subclassified into anterior and posterior encephalocele. Anterior encephalocele are further subdivided into sincipital and basal encephalocele. Sincipital encephalocele herniate anterior to the cribriform plate and typically present with a mass that is visible in the face, such as in the image on the right, and also with nasal obstruction, obligatoral breathing, and potentially also with meningitis. Basal encephalocele herniate posterior to the cribriform plate, and as such, the initial diagnosis can be missed and present later in life with nasal masses or severe snoring. The anterior fontanelle encephalocele are extremely rare, but when they do occur, they are typically located at the anterior angle of the fontanelle and in the subgaleal or subperiosteal spaces. They also require careful differentiation from similarly located lesions and may also enlarge over time, but are not typically associated with developmental disorder. For these lesions, resection is generally curative. However, this can be made more challenging when there is extensive attachment to the sinus. Temporal encephalocele are also very rare, and unlike other encephalocele, are most commonly secondary in nature, with only 20% of cases considered true congenital encephalocele. These lesions frequently present with recurrent otorrhea, rhinorrhea, meningitis, or otitis, and can additionally present with seizures and cranial nerve palsies, and are also frequently associated with hydrocephalus. Surgical management may require mastectomy and a temporal incision, which is used to harvest the temporalis fascia, section the herniated tissue, and repair the bony defect. Lateral encephalocele are also rare, representing around 1% of meningoencephalocele. They develop along the coronal or lambdoid suture, most typically at the confluence of the sutures, and present as a soft tissue mass. Developmental delay is rare, however, displacement of the ear and facial structures can occur with these lesions. Parietal encephalocele present as midline protuberances between the lambda and bregma and vary widely in size, shape, and content. Venous abnormalities are frequently seen, such as lateral distortion of the sinus or a high-riding straight sinus. The overwhelming majority of patients show significant developmental disability owing to the eloquent contents of these lesions, and hydrocephalus occurs in some 50% of cases. Occipital encephalocele also vary widely in size and contents, and can include cerebral and cerebellar tissue. Brainstem distortion and indeed herniation may also occur, and the spinal cord is invariably distorted in these lesions. The cord is pulled cranially, and there may also often be an enlarged central canal and hydromyelia. Hydrocephalus is common and occurs in 20 to 65% of cases, in particular when the ventricular system is involved within the lesion. Neurological sequelae are frequent and may include spastic paraparesis, developmental delay, and blindness if there is visual pathway involvement. The overall incidence of encephalocele is on the decline, and this is primarily attributable to two causes. First, widespread folic acid consumption and fortification has enabled for a reduction in the initial incidence, and additionally, improving access to antenatal care and screening allows for selective termination of fetuses known to have large encephaloceles. The CDC estimates that there are approximately 375 babies born each year with encephaloceles, and these diseases remain an important consideration for pediatric neurosurgeons, particularly in areas where access to antenatal care is poor or where therapeutic abortion is illegal. Also of note is a preponderance within East Asian populations for anterior encephaloceles. Abnormal maternal serum AFP values may hint at an initial diagnosis of an encephalocele, but they are typically diagnosed on prenatal ultrasound. However, basal encephaloceles and smaller sincipital encephaloceles may evade initial detection on ultrasound, owing to their location and size. And occult lesions may be later diagnosed by the identification of the hair collar sign, which has been defined as a ring-like hypertrichosis consisting of coarser and longer hairs surrounding a congenital alopecia lesion on the scalp. It may also be a sign of arthritic encephaloceles. The overall management of encephaloceles requires a complex and multifaceted approach. For the delivery, a planned caesarean section can allow for increased coordination of care between various specialists. It is worth noting, however, that while data suggests that planned caesarean sections for myelomeningocele decreases the risk of neurological deficit, there are to date no data to support this in encephaloceles. Despite this, caesarean section is recommended in particular for infants with large and solid encephaloceles, as this can complicate vaginal delivery. And in cases where there is extreme herniation of cerebral tissue through the defect, early counseling of the family about the utility of surgical management is warranted, in combination with consultation of the palliative care team and the hospital ethics committee. There are also a number of important anesthetic considerations in the management of encephaloceles. Large occipital encephaloceles can preclude supine positioning of the patient, and where there is substantial nasal herniation, intubation and ventilation can be challenging. We routinely ask our anesthesiology team to perform preoperative assessment of these patients, including an endoscopic evaluation of the airway anatomy. When considering the operative management of encephaloceles, the goals of surgery are manifold, and include preservation of viable brain, a watertight dural closure with adequate skin coverage, and the repair of any cosmetic deformity and optimization of cosmetic outcome, in particular when an incision in the face is required. Finally, cranial and craniofacial reconstruction is also a goal of surgery. In terms of the timing of surgery, whenever there is any CSF leakage, the lesion requires emergent treatment. For other lesions, early elective treatment is warranted to minimize the risk of further deformity and meningitis. When treating posterior encephaloceles, the patient is positioned prone with a padded pediatric horseshoe. The encephalocele is grasped and raised with forceps, and an elliptical incision is made around the sac close to the neck of the herniation. Blunt dissection is used to establish the bony margins of the defect, and the dural sac is cut and CSF drained. Any dysplastic appearing tissue is removed using suction and bipolar cautery and has been shown in studies to be non-viable brain. Our group uses an autologous split calvarial bone graft to repair the defect and provides for a very good reconstruction. The bone is placed between the dura and the pericranium, and the skin is closed. Here, the operative management of a child with a large occipital encephalocele can be seen. In the middle image, the encephalocele has been opened and the arachnoid lining of the sac has been exposed. In the third image, removal of the encephalocele has been performed and the bony defect is visualized. Research by this group has shown that herniated brain is rarely viable and can often be removed safely. A useful repair technique for the bony defect is to elevate the flap in an eccentric fashion, adding a more generous piece of bone off to one side, as can be seen here, and the bone flap is placed back after flipping it 180 degrees, and by doing so, normal bone is placed over the dural defect. The management of anterior encephalocele frequently requires a multidisciplinary approach, including colleagues from oral maxillofacial surgery, ENT, and plastic surgery. And there are multiple options for the treatment of these encephalocele. The traditional open approach using a bicoronal scalp flap and bifrontal craniotomy is still used. It enables extradural dissection of the sac from the skull base. This group has also had success using what has been called the sun visor approach, where a bifrontal craniotomy and wide facial degloving through the oral cavity can be used, allowing for a two-pronged approach to the defect while providing impressive exposure to the lesion. Additionally, endoscopic endonasal and transoral approaches are increasingly used as an adjunct and in some cases as a replacement to the standard transcranial approach. However, these can often be only performed after 2 to 3 years of age once the paranasal and frontal sinuses have become pneumatized, and are typically more appropriate for smaller, more localized lesions. When repairing the skull base defect, split calvarial bone grafts are used by this group, and we no longer implant any foreign material owing to the unacceptably high rate of infection in and around the sinuses. Here in the image on the left, the sun visor approach has been used, providing wide facial degloving and exposure of the encephalocele, as can be seen in the midline. This allows for the simultaneous reduction of the lesion both transnasally from below and transcranially from above. In the second image, the surgeon's view during a frontal craniotomy can be seen, demonstrating the defect in the anterior fossa floor after removing the encephalocele. The operative management of temporal encephalocele is similar to that of CSF fistula repair in this region, and the goals of surgery include management of the herniated intracranial contents, repair of the bony defect, and, where possible, maintenance of the conductive hearing system. Open repairs are frequently successful, however, there is recurrence in up to 40% of cases. Operative approaches are numerous and include the subtemporal, transmastoid extracranial, or transmastoid extradural intracranial approaches. Subtemporal approaches provide superior access to the tympani and preservation of the hearing apparatus, but are more invasive. In contrast, the transmastoid approaches avoid the need for substantial temporal retraction, but may put the facial nerve and the ossicles at risk. Recently, endoscopic approaches have been used with fewer complications and with similar outcomes. Generalized prognosis for encephalocele is difficult and is primarily dictated by the volume of brain tissue contained within the herniated sac, and also the overall size of the encephalocele. Hydrocephalus and the coexistence of other anomalies portend a poorer overall prognosis, and in general, anterior encephalocele are associated with more favorable prognosis than posterior encephalocele. In conclusion, the variable anatomy, location, and extent of encephalocele often makes generalized prognostication challenging. The treatment should always be tailored to the individual patient, and where appropriate, endoscopic and nasal techniques may now be used. A multidisciplinary management approach is frequently warranted, drawing upon the expertise of multiple specialists. We hope that this PowerPoint has provided an overview of the encephalocele and has offered key insights into their management. For a full discussion of the encephalocele and the other cranial dysraphisms, please visit the full print chapter. Thank you.